Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a posterior subcapsular cataract with nuclear sclerosis of grade 2. Let us observe this surgery. After a thorough irrigation of the ocular surface, this is the main incision with a 2.8 mm steel keratome at 135-degree axis. And now this is a side port on the left side of the main incision, and now 2% SPMC is used to fill up the anterior chamber, and it is applied over the corneal epithelium for better visibility. Now let us observe capsulorhexis. The anterior capsule is pierced by the tip of the uterata forceps. A capsular tag is raised and the tag is guided anticlockwise to do an adequate sized continuous curvilinear capsulorhexis. Now hydrodissection. BSS is passed just under the anterior capsular rim with a 27 gauge cannula, and hydrodelineation is also attempted, and then the nucleus is rotated. And now visco is again used to fill up the anterior chamber, and then the tip of the phaco needle is introduced into the anterior chamber. Some superficial cortical lens matter is aspirated. The nucleus is rotated both clockwise and anticlockwise, and now the handpiece is turned to make the bevel up. Now watch direct chop. In this case we will be able to hold at the center. Yes, here must not go beyond the center. Beyond the center the nucleus is soft and we may not be able to hold there. So in grade 2 nuclear sclerosis we can hold at the center where the nucleus is reasonably holdable. Now the nuclear pieces are emulsified using ultrasonic energy. In this case the ultrasonic energy was set at 60%, but it was not 60% energy was not used most of the time. And now watch removal of the cortex by the handpiece itself. At this time I am in very low vacuum, controlling by the foot switch, and I am very carefully removing the subincisional cortex. So most difficult part is done easily, but here some cortex is there at 6 o'clock which I was afraid to aspirate. So what I am going to do is I am going to inject some visco and I'm going to use a 23G Simcoe to remove this cortex. So we must be very careful in removing the cortex if we are using the handpiece itself. If we are using the phaco needle itself to remove the cortex, we must use very low vacuum and we must have patience to very slowly aspirate the cortical lens matter. In this case we are going to use a B cartridge to implant the lens, so I enlarge the main wound to about 3 mm. Now this is hydroimplantation of a single piece monofocal hydrophilic intraocular lens. The lens has gone into the capsular bag. Now the lens is dialed. The capsular bag is also irrigated. The antechamber is also irrigated, and now we are towards the end of the surgery. This is a real-time surgery, and you are watching each and every step of the surgery. Now this is a bit of moxifloxacin. Now in this case we did only one side port. Corneal stroma on either side of this stab incision is hydrated to close the side port. And now our final lavage of the anterior chamber. At this time, whatever visco sticks to the corneal endothelium comes out. Any debris or anything comes out, but lot of moxi molecules stays to control the infection. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.